Assalamu alaikum. Our topic for today is going to be leukemia.
Leukemia is cancer or malignancy of blood due to uncontrolled clonal growth of malignant hematopoietic precursor cells in the bone marrow. It is either acute leukemia, which is acute myelogenous leukemia, AML, or acute lymphoblastic leukemia, ALL. I thought to add myelodysplastic syndrome because it is a pre-leukemic condition that may progress and transform into acute myelogenous leukemia. Chronic leukemia is the other kind of leukemia. It is either chronic lymphocytic leukemia (CLL) or chronic myelogenous leukemia (CML). We are going to discuss these two types of leukemia separately.
Myelodysplastic syndrome, or MDS, is a pre-leukemic condition. MDS, myelodysplastic syndrome, is a hematologic malignancy characterized by clonal hematopoiesis associated with cytopenias, anemia and/or neutropenia, and/or thrombocytopenia, at least one of the three cytopenias. Bone marrow will show dysbiosis or dysplasia and blast less than 20%, because blast of 20% or more is a definition of acute leukemia. What are the causes of MDS? It was noted that up to 10% of healthy asymptomatic adults by age of 70 may have a clonal hematopoiesis of intermittent potential (CHIP), similar to MGUS, monoclonal gammopathy of unknown significance for multiple myeloma, equivalent to that. Also noted those patients may have MDS-associated mutation without cytopenias. Another cause is exposure to chemotherapy and/or radiation. This is what we call therapy-related MDS. Environmental toxins, again, irradiation, not therapeutic, but irradiation, nuclear, or benzene, which used to be a way to clean or jewelries, and also in some factories. Tobacco also is considered a risk factor for MDS. Inherited or genetic factors, trisomy 21, Fanconi anemia, Bloom syndrome, ataxia telangiectasia, PNH, paroxysmal nocturnal hemoglobinuria, congenital neutropenia. These are risk factors for MDS. Presentation: fatigue due to anemia, fever or infection due to neutropenia, easy bruising due to thrombocytopenia, or the patient may not be symptomatic, just found to have cytopenia in a routine CBC. Cutaneous signs of transformation of MDS to acute leukemia. Sweet syndrome. It is an acute febrile neutrophilic dermatosis. Myeloid sarcoma, granulocytic sarcoma, or chloroma. Diagnosis of MDS. Because cytopenia is one of the characteristic features of MDS, CBC with the manual diff should be the first diagnostic test. The CBC may show
hemoglobin of less than 10 gram per deciliter, absolute neutrophil count or ANC less than 1.8. For some ethnic group, the cutoff is 1.5 like Africans. Platelets count less than 100,000 and dysbiosis or dysplasia in the bone marrow. For MDS, we expect the dysplasia to be 10% or more of the nucleated cells in at least one of the lineage. And the blood or the bone marrow may show a blast of less than 20%. Remember, 20% or more blast in the blood or bone marrow is defined as acute leukemia. MDS may be associated or characterized by certain characteristic cytogenetic findings, molecular or fish findings. Chromosomal abnormalities. This slide displays the most common chromosomal abnormalities or cytogenetics found in MDS. Monosomy 7, deletion 5q, deletion 13, and so on. The list is long. On the upper right here are the three common chromosomal findings, but not criteria for MDS. Acquired loss Y chromosome, which could occur with aging, trisomy 8, and deletion 20q. In the right lower corner here are the cytogenetics abnormalities characteristic or diagnostic for AML, acute leukemia, regardless of the percentage of the blast. If you find any of these translocation between chromosome 8 and 20, versus 16, and translocation 15, 17, which is pathognomonic or diagnostic for APL. This is the WHO classification for MDS. MDS with single lineage dysplasia, MDS with multi-lineage dysplasia, MDS with ring sideroblast, MDS with excess blast, MDS with isolated deletion 5q, and MDS unclassified. This slide displays the International Prognostic Scoring System. This system is very important to decide treatment. It is based on cytogenetic findings, the percentage of the blast in the bone marrow, the hemoglobin, the platelet count, and the absolute neutrophil count. From those 5 factors, we come up with a risk group, very low risk, intermediate, high, and very high, and these are used to decide the therapy. MDS treatment. Treatment of MDS is guided by stratification based on the IPSS revised system, and it is risk group. The only curative treatment for MDS is allogeneic hematopoietic cell transplant or bone marrow transplant. This is the only curative treatment. Treatment for high or very high risk MDS. Those are the patients with the median overall survival of 0.8 to 1.6 years. So they are high risk patients, may develop acute leukemia and may die from their disease in a short period of time. So we treat those patients aggressively. For medically fit young patients with MDS with adverse genetic features such as TP53, monosomy 7, or has 3 or more chromosomal abnormalities, those patients, we counsel them and recommend for them allogeneic hematopoietic cell transplant, allogeneic bone marrow transplant, or at least hypomethylating agents, azacitidine, decitabine, or the new decitabine in COVID. For patients with no adverse genetic features and patients with IDH mutation, we treat them with targeted therapy, IDH inhibitors. But if they don't have actionable mutation, we go to the option of allogeneic stem cell transplant or hypomethylating agent, azacitidine or decitabine. Chronic myelomonocytic leukemia, or CMML, is considered one of the MDS types. It is characterized by persistent monocytosis for 3 months or more. Monocytosis defined as absolute monocyte count of more than 1 and more than 10% of the total WBC. It is treated with allogeneic stem cell transplant. We use hydroxyurea for myeloproliferative bone marrow. And for cytopenia associated with CMML, we do treat with hypomethylating agent, decitabine or azacitidine. Of course, this is in addition to supportive care, transfusions as needed, and antibiotics as needed.
Here are the topics for today. Myelodysplastic syndrome, MDS, acute myelogenous leukemia, AML, and acute lymphoblastic leukemia, ALL.
Now we move to acute leukemia, and we are going to discuss acute myelogenous leukemia, AML. AML is characterized by clonal proliferation of myeloid precursors that not able to differentiate and reach the mature forms or neutrophils. Presentation of AML could be vague or somewhat specific. The patient may present with fatigue due to anemia, fever due to neutropenic fever or infection, some form of bleeding such as easy bruising or gingival hypertrophy, which is characteristic for the monocytic leukemia, or the patient may present with some kind of skin or soft tissue swelling, which is myeloid sarcoma or granulocytic sarcoma, or also called coloroma, or the patient may be found to have an abnormal CBC. The AML may present as an emergency due to leukostasis or tumor lysis syndrome with acute renal failure, bleeding or coagulopathy, or unexplained neurologic or visual disturbances due to leptomeningeal disease. Diagnosis of AML. Initial workup is a CBC with the manual diff. The CBC commonly shows moderate elevation of WBC around 15,000, but rarely we see either very high WBC, 100,000 or more, or we may see leukopenia with WBC of less than 5,000. Peripheral blood smear may reveal circulating myeloblasts. If it is more than 20% or more, this is diagnostic for AML. Bone marrow. Typically, the bone marrow is hypercellular with immature or undifferentiated cells, but sometimes the bone marrow could be hypocellular. The WHO classification consider blast of more than 20% or more is diagnostic for AML. The FAB, French American British classification, they define AML with the if the blast 30% or more in the bone marrow. The bone marrow blast could be myeloid, monocytic, erythroid, or megakaryocytic in origin. Immunohistochemistry is positive for myeloperoxidase, Sudan black B, chloroacetate esterase. If you find our rods in the blast, this is pathognomonic for AML. Flow cytometry is characteristic for cluster of differentiation CD34, CD13, CD33, and CD17, in addition to others. Cytogenetics could be very characteristic for AML. We'll review them in the next slides. Also, there are some molecular studies that could help and may have a therapeutic implication. There are some chromosomal abnormalities or diagnostic for AML regardless of the percentage in the peripheral blood or the bone marrow. These are chromosomal translocation between chromosome 8 and 21, inversion 16, translocation 16-16, the APL gene mutation, PML, RARA, which is the gene of product from the translocation chromosome 15-17. These chromosomal abnormalities are diagnostic for AML by themselves. Also, the presence of myeloid sarcoma or chloroma, biopsy proven, is diagnostic for AML regardless of the blast percentage in the peripheral blood or bone marrow. Very busy slide. This is the WHO classification with all kind of cytogenetic abnormalities. Now we made the diagnosis of AML. We need to treat. Initial evaluation, we need to evaluate the patient carefully to make sure he or she eligible for induction chemotherapy. Of course, we start with history and physical. We assess for performance status using either ECOG or Karnavosky scale. ECOG stands for Eastern Cooperative Oncology Group. Score 0 means the patient is asymptomatic, which is unusual for someone with leukemia. Score 1, minimally symptomatic, such as fatigue, shortness of breath during exertion, those kind of symptoms. Score 2, up and around more than 50% of the time and not spending the time in the bed. Score 3, more than 50% in the bed, so really symptomatic. And score 4, bedridden. We need to look into the comorbidities, ask about chronic diseases, diabetes, hypertension, heart disease, COPD, and if the patient is a smoker, those kind of things, chronic diseases and comorbid conditions. Ask about history of chemotherapy and or radiation to rule out therapy-related MDS that transform into leukemia, which is hard to treat. and this is versus de novo AML, which is more easy to treat than the therapy-related AML. Family history for hereditary diseases such as Fanconi anemia, cardiac evaluation, baseline EKG or ECG, echocardiogram, because you'll be using anthracycline, which is a cardiotoxic drug. Liver function test for the same reason. Anthracycline is hepatotoxic drug. Renal function, you'll be using cytarabine, RSC, which is a nephrotoxic drug. Check for the COAG, PT, PTT, fibrinogen levels, especially in patients with APL. Screening for viral infections, HPV, hepatitis C, HIV, CMV, and tuberculosis. HLA typing if you think your patient is going to be a bone marrow candidate. Of course, you do need double or triple lumen central venous catheter because you will be giving fluid, antibiotics beside the chemotherapy, blood and blood products transfusion. So you need at least double lumen, if not triple lumen central venous catheter. Neutropenic precaution, those patients typically treated in an isolated area. You need your infectious disease specialist on board to be with you because you do need either prophylactic antibiotics or to treat neutropenic fever and sepsis. Transfuse blood and blood products as needed. Typically, we do use irradiated blood and blood products.
Now, we made the diagnosis. We evaluated our patient to make sure he or she is fit for the induction chemotherapy. The idea of the induction chemotherapy basically is to wipe out the bone marrow, kill the good and bad guys, everything. Everything should be gone. That's the induction chemotherapy. Hoping that the bad cells never come back, the good cells do come back and take over. That is the remission. So how we do that? It is basically based on the age of the patient and the comorbid condition. If our patient is young, young means less than 6 years old, and medically fit, we give traditional chemotherapy, very standard. We call it 7+3 induction chemotherapy. 7 days of cytarabine or RAC and 3 days of anthracycline. Typically, we use daunorubicin, with or without targeted agents, if available. Then we do a bone marrow on day 14, maybe up to day 21. But day 14, we do a bone marrow to make sure all the bone marrow has been wiped out. Hypoplastic bone marrow with cellularity less than 5%, maybe up to 20%. Well, the more is hypoplastic the bone marrow is better. But at least the blast should be less than 5%. During this time, the patient needs a lot of support. Blood, platelet transfusions, antibiotics, and again, you make sure ID consultation is available for you, ID people available for you, be with you all the time because you do need them. Because the patient at this time has no immunity whatsoever. They get all kind of opportunistic infections. That means they may be on prophylactic antibiotics, viral, fungal, bacterial. So they do need support. Isolate them. At this time, all food should be cooked. No flowers, nothing like that in the room. Basically, a clean environment. Then, hopefully by day 21, the bone marrow starts coming back. By day 28 and after, should recover. So we do another bone marrow on week 4 to 5 to make sure the bone marrow recovers. This is a successful induction therapy. If your patient is still young but medically unfit, comorbid conditions, they are not well enough to handle aggressive chemotherapy. So we do use mild chemotherapy. We call them uh, hypomethylating agents, azacitidine, decitabine, dacogene, Vidasa, with or without targeted therapy, venetoclax or Venclexa, or a low-dose cytarabine and Venclexa, another option. If your patient is an elderly, not in a good shape, then we use the hypomethylating agent, again, with or without Venclexa. Or if they are elderly but in a good shape, we could try 7 plus 3, the same like the medically fit young patient. Or we could use a less toxic anthracycline, liposomal daunorubicin. That's another option. Again, these patients, they do need a lot of support during the induction therapy.
Post-remission therapy for younger adults. Options are consolidation chemotherapy, autologous hematopoietic cell transplant, or allogeneic hematopoietic cell transplant, bone marrow transplant. Young medically fit patients who received intensive induction chemotherapy, typically they achieve complete remission 60 to 80% of the time. Very high, very good result. It was a rough road, but good result. However, unfortunately, without additional post-remission cytotoxic therapy, relapse occurs within 4 to 8 weeks. It doesn't last long. But post-remission therapy gives them a good chance. It's the 5-year survival of 40%, and 1/3 of them will be cured. So never stop at the induction therapy, and don't celebrate and stop by the induction therapy. So we have to complete the course. Relapsed or refractory AML, allogeneic stem cell transplant recipient, either we treat them with a second transplant or we could use the donor lymphocyte infusion, DLI. Autologous stem cell transplant recipient, if they have FLT mutation, we could use the FLT3 inhibitor, galtretinib, or another inhibitor if they have mutation of IDH1. Acute promyelocytic leukemia, APL. It is a special entity of AML. In the coming 2 slides, I will try to summarize APL very briefly. APL is the clinical diagnosis. It is an acute leukemia with AML features plus DIC. That's why it is a medical emergency. Treatment of APL should be started immediately once we suspect AML using all trans-retinoic acid ATRA before confirming the diagnosis, because it would be too late to wait for cytogenetics or molecular study to confirm the diagnosis. Once you suspect APL, you treat, and you treat with ATRA. APL variant may not respond to ATRA. The laboratory diagnosis of APL is very characteristic. First of all, under the microscope, the leukemia cells are atypical promyelocytes. They appear large with creased or folded or bilobed nucleus. The cytoplasm filled with bright pink or reddish blue or dark purple granules. If you see the atypical promyelocyte APL cells are very characteristic and you will never forget them. They are CD13 and CD33 positive. But the confirmatory test is a cytogenetics with translocation 1517 or molecular study that reveals the uh, diagnostic gene PML or RARA fusion gene. This is diagnostic for APL. This is a confirmatory test if you are in doubt. Treatment of APL depends on the white count at time of presentation. If the WBC count is low, less than 10,000, this is considered low or intermediate risk APL. And especially for elderly patients, we may use non-chemotherapy induction regimen using ATRA plus arsenic trioxide, ATO. However, if arsenic trioxide not available, we could use chemotherapy in addition to ATRA for induction. Consolidation, we use the ATRA and ATO. For high-risk patients with WBC more than 10,000, the standard of care is ATRA plus chemotherapy daunorubicin or anthracycline. If we use ATRA and arsenic trioxide, we have to be very careful because we may see the situation of hyperleukocytosis or differentiation syndrome, which we will discuss later. If we use ATRA and arsenic trioxide, we continue treatment, but we don't exceed 60 days of therapy. Consolidation, we either use the ATRA plus chemotherapy or ATRA plus ATO. Maintenance therapy, for low or intermediate risk, if we use ATRA and ATO, we just observe patients. Otherwise, for high risk, we continue ATRA for 1 year or combination of oral chemotherapy plus ATRA. Complication of therapy. When you use ATRA and arsenic trioxide, ATO, we may end up with some complications. One of the most common complications during this therapy is differentiation syndrome, also called retinoic acid syndrome or cytokine storm. It is characterized by fever, edema, pulmonary infiltrates, respiratory distress, hypertension, renal and hepatic dysfunction, pleural or pericardial effusions, and that's with or without hyperleukocytosis. Treatment is steroids, dexamethasone, 10 milligrams twice a day for at least 3 days. Don't stop or hold ATRA or ATO. Only if there is renal failure or respiratory distress or failure. Hyperleukocytosis may exacerbate coagulopathy, which is a feature of APL. If that happens, add chemotherapy, daunorubicin to ATRA. Another rare complication of ATRA is pseudotumor cerebri. Do LP interrupt or reduce dose of ATRA? Use analgesic steroids and acetazolamide for the treatment. Refractory or relapsed APL. Use 2 courses of arsenic trioxide and then prepare for autologous stem cell transplant if the patient achieves remission. Targeted therapy is another option in case of relapsed or refractory APL. Now we switch to the second type of acute leukemia, acute lymphoblastic leukemia, ALL. There are 2 types of acute lymphoblastic leukemia, either B-cell ALL or lymphoblastic leukemia or lymphoma, which has gone through a lot of changes in regard to the name. It used to be called pro-B lymphoblastic leukemia, common precursor B lymphoblastic leukemia, B lymphoblastic leukemia, common lymphoblastic leukemia, and so on. B cell acute lymphoblastic leukemia. All these different names means the same thing. It is acute lymphoblastic leukemia or lymphoma. Or it could be a T cell, T lymphoblastic leukemia lymphoma. ALL is a childhood disease or leukemia. Presentation: pallor due to the anemia, fever, bruising, abdominal pain, distension due to hepatosplenomegaly, lymphadenopathy, SVC syndrome due to mediastinal mass in T-cell lymphoblastic lymphoma or leukemia, bone pain, painless testicular mass, or simply an abnormal CVC with lymphoblast. Diagnosis: CBC with manual diff, peripheral blood smear will show lymphocytosis and lymphoblast. Bone marrow: no consensus regarding the minimal lymphoblast in the bone marrow, but generally avoid the diagnosis if lymphoblast in the bone marrow less than 20%. It is always positive for B cell biomarkers, CD19, CD79. Most positive for CD10, CD24, PX5, TDT, terminal deoxytransferase, CD3 negative, CD13 and 33, which are markers for myelogenous leukemia AML. If expressed, does not exclude diagnosis of B cell acute lymphoblastic leukemia or lymphoma. However, myeloperoxidase expression, if present, it does exclude ALL. So myeloperoxidase is characteristic for myelogenous leukemia. Induction therapy: induction for Philadelphia negative B ALL is actually complicated regimens. Here are the regimens that could be used for induction: the CLDB protocol, Dana-Farber Cancer Center Institute, or a more simple regimen, or Hyper-CVAD, and these are other regimen for induction for the Ph negative, Philadelphia chromosome negative BALL. Post-induction therapy for Philadelphia negative BALL. For high-risk patient, allogeneic stem cell transplant. For the standard risk, we could use consolidation chemotherapy followed by maintenance. Induction for the Philadelphia positive BALL. It is a low-intensity chemotherapy because we'll be using the tyrosine kinase inhibitor, especially dasatinib or Sprycel, along with chemotherapy. It does target the BCR-ABL gene. So dasatinib or Sprycel is the preferred regimen given with chemotherapy. If patient not candidate for chemotherapy, we could use the same tyrosine kinase inhibitor, Sprycel plus steroid. Post-induction for Ph positive or Philadelphia chromosome positive BALL, if medically eligible patient, the best choice is allogeneic hematopoietic cell transplant, stem cell transplant. Otherwise, we could use autologous stem cell transplant or tyrosine kinase inhibitor plus consolidation chemotherapy. Maintenance is again tyrosine kinase inhibitor alone. Relapsed or refractory ALL, remission induction for Philadelphia chromosome negative BALL in the relapse setting. Here are the choices, including CAR-T. For Ph-positive ALL, tyrosine kinase inhibitor-based therapy. Dasatinib is the most effective tyrosine kinase inhibitor, but you could use Gleevec. T-cell acute lymphoblastic leukemia or lymphoma could present in the form of lymphoblastic leukemia, precursor T-cell ALL, or a bone marrow with more than 25% blast with or without mass lesion, or a precursor T-cell lymphoblastic lymphoma, or a bone marrow with less than 25% blast plus a mass, typically mediastinal mass. Treatment: we use induction, consolidation, and maintenance with intrathecal chemotherapy. Regimens are complicated, basically research protocols. And if the patient has the BCR-ABL translocation, so you could use tyrosine kinase inhibitors. ATL, adult T-cell leukemia lymphoma, is the special entity of acute lymphoblastic leukemia or lymphoma. It is associated with viral infection, human T lymphotropic virus type 1, HTLV1. Under the microscope, you may see clover leaf or flower cells, one of the characteristics of this lymphoma or leukemia, associated with hypercalcemia and risk for TLS, tumor lysis syndrome. Patients are at risk for opportunistic infection, PCP, Candida, CMV, and stranguloids. There are 4 variants of ATL, either acute, lymphoma type, chronic, and smoldering. We observe patients with chronic and smoldering disease, and we do treat the acute and lymphoma type with complicated chemotherapy regimens. Now we are going to discuss the chronic type of leukemia, which is either chronic lymphocytic leukemia, CLL, or chronic myelogenous leukemia, CML. We are going to start with chronic lymphocytic leukemia, lymphoproliferative neoplasm, CLL. But sometimes you may come across a different name for this disease. Small lymphocytic lymphoma, SLL. It is the same disease. They present similarly, prognosis is similar, and treatment is similar. CLL or SLL is actually a progressive accumulation of mature B cells. Like any other cells, lymphocytes should enter the program cell death and end up dying. However, in CLL or SLL, those cells they do not die. They keep accumulating. So if they accumulate in the blood, we call it CLL. But if those cells accumulate in lymph nodes, we call the disease SLL. So it is the same disease. Presentation: patient with CLL, most of the time asymptomatic, only found to have an abnormal CBC with asymptomatic lymphocytosis. Under the microscope, the smear may show a lot of mature lymphocytes. or the CBC may show anemia and or thrombocytopenia. Anemia or thrombocytopenia could be autoimmune due to peripheral blood destruction, or could be due to low production due to bone marrow infiltration by CLL. The patient also may be asymptomatic but only has painless enlarged lymph nodes, asymptomatic lymphadenopathy, which may wax and wane. Or the patient may be symptomatic with one of the B symptoms, either fever without infection, night sweats, or weight loss, or just fatigue. Another presentation is history of recurrent infection. CLL is known to be associated with hypogammaglobulinemia, low IgG level, immune deficiency. Diagnosis: if you find a patient with lymphocytosis, it is not CLL until you find an absolute B lymphocytes count, ALC, 5,000 or more and persistent for at least 3 months. Not only that, those lymphocytes should be monoclonal. There is clonality with either kappa or lambda restriction, and the immunophenotype should be CD19, CD20, CD23, and CD5. This is the phenotype of CLL. Or if the absolute lymphocyte count is less than 5,000 and the cells are monoclonal, to make a diagnosis of CLL, you do need lymphadenopathy and or hepatosplenomegaly or disease-related cytopenias due to bone marrow infiltration. If none present, no lymphadenopathy, no hepatosplenomegaly, no cytopenias due to bone marrow infiltration, then you are not dealing with CLL. You are dealing with what is called monoclonal B-cell lymphocytosis. Monoclonal B-cell lymphocytosis, because of the absolute lymphocyte count of less than 5,000 without lymphadenopathy, without hepatosplenomegaly, without cytopenias. Or you could make a diagnosis in case of lymphadenopathy, splenomegaly, or extramedullary involvement of tissues, even without cytopenias, biopsy proven that shows kappa or lambda restriction and the same immunophenotype CD19, 20, CD23, CD5 positive, then you are dealing with small lymphocytic lymphoma, which is the same disease, but there is no cytopenias and maybe there is no lymphocytosis. So it is a tissue diagnosis. There are two staging systems for CLL. RISE staging system used in US. Stage 0 lymphocytosis in blood or bone marrow. Stage 1 lymphocytosis plus lymphadenopathy. Stage 2 hepatosplenomegaly or splenomegaly. Stage 3 anemia, hemoglobin less than 11. Stage 4 thrombocytopenia, platelets less than 100. Beneath the staging system used in Europe, stage A, 2 or less areas of lymphoid tissue involved by CLL or SLL. Stage B, 3 or more areas of lymphoid tissue involved. Stage C, anemia, hemoglobin less than 10, or thrombocytopenia, platelets count less than 100. Treatment of CLL or SLL. Uh, these are the indication for treatment because we don't treat all CLL because CLL is an indolent disease that the patient, most of the time, they live with it, they die with it, but they don't die from it. And also, it is not a curative disease. So we don't treat all patients. So we are very selective in regard to treatment. So these are the indication for treatment. Advanced stage, stage 3 and 4, CLL associated with anemia and or thrombocytopenia, high tumor burden, large lymph nodes, large matted lymph nodes or splenomegaly that's causing symptoms, high tumor burden, anemia or thrombocytopenia, even severe autoimmune anemia or thrombocytopenia. We may start with steroids. Severe disease-related B symptoms. Remember the B symptoms: fever, weight loss, night sweats. In addition to those clinical factors or features, we do use prognostic features for treatment. I would like you to remember those three unfavorable features at the top: deletion 17p, deletion 11q, and unmutated IGHV. Those are poor prognostic features. We use them to guide treatment. Bone marrow infiltration, the diffuse pattern carries a progressive course. Treatment options. Again, we don't have to treat all patients. Patients who are asymptomatic and they don't have those poor prognostic features, we may just observe them, monitor them with blood tests every 3 to 6 months. It depends, and of course, physical exam for adenopathy. So observation is very reasonable. However, when we decide to treat, we have a couple of options. Chemotherapy, traditional chemotherapy, either chlorambucil or bendamustine. Bendamustine infusion is the most commonly used chemotherapy, and we use it along with an anti-CD20 rituximab immune therapy. But nowadays, there are non-chemotherapy options. The most commonly used are proton tyrosine kinase inhibitors, with or without anti-CD monoclonal antibody, rituximab. But the most effective and commonly used regimen is Venclexta, which is an oral drug, not a chemotherapy drug, with an anti-CD Gazyva. This is the only non-chemotherapy regimen used for only certain period of time, which is 12 months, because the proton tyrosine kinase inhibitors, for example, ipratinib, is an oral drug, but it is not for a certain period of time. You just keep taking it forever, for life, as long as the patient is tolerating and as long as no side effects. And it is very expensive drug. But Venclexta with monoclonal antibody Gazyva is only given for 12 months and done. And the outcome is great. Also, we could just use monoclonal antibody, Gazyva or rituximab. For refractory disease, there are new agents, PI3K inhibitors. They are toxic drugs, some of them oral, but they have a lot of side effects. They are listed here. Two slides about two conditions somehow related to CLL. Monoclonal B-cell lymphocytosis. I think we mentioned this before. It is characterized by monoclonal B cell lymphocyte count in the peripheral blood, but less than 5,000 for 3 months or more. That is a diagnosis of monoclonal B cell lymphocytosis. Remember, with this condition, it should not be any of the B cell lymphoproliferative disorders. That means no lymphadenopathy, no organomegaly, no splenomegaly, hepatomegaly, no cytopenia, and no extramedullary disease. Just pure lymphocytosis less than 5,000. Of course, we don't treat this condition. B cell prolymphocytic leukemia. It is a disease of blood, bone marrow, and spleen, characterized by very high WBC count, more than 100,000, a massive splenomegaly, and it has immunophenotype characterized by pan B cell biomarkers, CD5, CD10 negative. For treatment, we use CLL regimens. The second type of chronic leukemia is chronic myelogenous leukemia, CML, which is one of the chronic myeloproliferative neoplasm, MPN. Chronic myelogenous leukemia. CML is characterized by fusion of BCR on chromosome 22 and ABL1 on chromosome 9. This fusion leads to BCR-ABL fusion gene, which is a translocation between chromosome 9 and 22 located in chromosome 22, known as Philadelphia chromosome. The BCR-ABL gene is the driving gene for CML, causing uncontrolled production of mature and maturing granulocytes, which infiltrates the bone marrow and other tissues, especially the spleen. Also, the BCR-ABL gene produces a BCR-ABL protein, which we could quantify and measure in the blood to follow the progress of the disease and response to treatment. CML presentation. Patients with CML could be totally asymptomatic, only found during routine lab work to have an abnormal CBC, which will show neutrophilia with the left shift, or complaints of fatigue, weight loss, sweating, or abdominal fullness and early satiety due to splenomegaly, or abdominal pain due to splenic infarction, or gout symptoms due to hyperuricemia due to high turnover of granulocytes. Diagnosis of CML. To diagnose CML, you need a blood test and a bone marrow aspiration and biopsy. CBC is characterized by neutrophilia with the left shift. You will find increased mature neutrophils, increased bands. You will find myelocytes and metamyelocytes, as well as blasts. But typically, the blasts are few, less than 2% in the chronic phase. It could be more for the accelerated or blast crisis. Basophils and eosinophils are increased in the peripheral blood. LAB score, leukocyte alkaline phosphatase, is low. Bone marrow is very characteristic.
The bone marrow characterized by granulocytic hyperplasia. The bone marrow is packed with increased reticulin fibrosis and vascularity. Cytogenetics is the key to diagnose CML. Conventional cytogenetics will show translocation chromosome 9 and 22, which is Philadelphia chromosome located in chromosome 22. FISH and PCR will show the BCR ABL gene. But sometimes the conventional cytogenetics could be negative for the Philadelphia chromosome. In that case, the BCR and FISH are very crucial to make the diagnosis. So it should be done. However, there is what is called Philadelphia negative CML. It is very well known. It is rare, but very well known. But before we call it a Philadelphia negative CML, we should do the FISH and the PCR test. Down here are the BCR ABL transcripts or the proteins, the P210, the P230, P190. Those are the protein which we could measure in the peripheral blood to monitor the progress of the disease and response to therapy. Imaging, abdominal ultrasound will show splenomegaly, sometimes hepatosplenomegaly. If we do a CT scan, lymphadenopathy is very rare. There are three phases of CML. The chronic phase, which is a stable phase, characterized by neutrophilia with the left shift, bone marrow infiltration, and sometimes splenomegaly. Accelerated phase. Here is the WHO criteria for the accelerated phase. To call CML in an accelerated phase, we have to have one of the followings. Blast in the bone marrow or blood in the range of 10 to 19%, basophils in the blood at least 20%, platelets count less than 100,000, thrombocytopenia, but should be not related to therapy, or thrombocythemia with platelets count more than 1 million, unresponsive to therapy, or progressive splenomegaly and leukocytosis or neutrophilia, unresponsive to therapy, or cytogenetic evolution with a gain of some chromosomal abnormalities in addition to the Philadelphia chromosome. Blast crisis, which is equivalent to AML, and this is the WHO criteria for the blast crisis. We have to have at least one of the following. Blast in the peripheral blood or bone marrow 20% or more, which is similar, or this is the exact definition of AML actually. Or if there are large foci or clusters of blast in the bone marrow biopsy. Or if there is extramedullary blast infiltrates, which we call myeloid sarcoma, granulocytic sarcoma, or chloroma. Before initiating any treatment, we obtain a baseline blood counts, renal and liver function, uric acid level, LDH, hepatitis B profile, and EKG or ECG, because some of the tyrosine kinase inhibitors may cause QT prolongation, which is a risk for arrhythmias. Baseline quantitative PCR for BCR ABL, risk stratification, such as SOCAL, which takes in account the spleen size, percentage of the blast, age, and platelets count. Treatment of CML was historically by using chemotherapeutic agents. hydroxyurea, busulfan, and sometimes immune therapy interferon. For young, healthy patients, we used to treat them with allogenic stem cell transplant or bone marrow transplant with curative intent. However, and fortunately, in the late 1990s, targeted therapy was discovered, and tyrosine kinase inhibitors was one of the first class of these drugs. Tyrosine kinase inhibitors, such as imatinib or Gleevec, which was the first of this class, work by inducing apoptosis or programmed cell death. They inhibit Philadelphia chromosomal tyrosine kinase and myeloid leukemic cell proliferation. They lead to complete remission at the level of cytogenetics and even molecular. Nowadays, treatment of CML is much easier. It is by using tyrosine kinase inhibitors. For example, for the chronic phase, we use tyrosine kinase inhibitor imatinib or Gleevec, which is the first generation of this class, or we could use the second generation, such as dasatinib or Sprycel, nilotinib or Tasigna, bosutinib or Busolif. They do have faster and deeper response. For the accelerated or blast phase, we still use tyrosine kinase inhibitor to convert those phases back into the chronic phase, and then we treat them with stem cell transplant and post-transplant tyrosine kinase inhibitors such as imatinib. The goal of therapy is obviously to control the disease and achieve a remission. The first step is the hematologic response. So we would like to achieve a hematologic response as soon as possible by controlling blood counts. WBC should be less than 10, basophil less than 5%, platelets less than 450,000. Of course, should not be any immature WBCs, no blasts in the peripheral blood. The spleen should be back to normal, not palpable. Then we look for cytogenetic response. The major complete cytogenetic response is complete disappearance of the Philadelphia chromosome or by FISH or PCR, the BCR-ABL protein should be less than 1%. The minor response, the Philadelphia chromosome dropped by 36 to 65%. But the ultimate goal is the molecular response, which is almost disappearance, if possible, of the BCR-ABL gene. So we quantify the BCR-ABL protein in the blood by using the PCR technology. Of course, drug resistance could happen by mutation of the BCR-ABL, and the most common is the BCR-ABL T1315I gene mutation. This gene mutation leads to resistance to most of the tyrosine kinase inhibitors. However, there is new drugs that could overcome this mutation.
Once the patient initiated on tyrosine kinase inhibitor should be monitored very closely to assess for response by doing, of course, CBC, but the most important is quantitative PCR every 3 months for BCR-ABL protein. The first 3 months, the BCR-ABL protein should drop down to less than 10%, and if you check the Philadelphia chromosome, it should drop to less than 35%. This is considered an optimal response in the first 3 months, and you continue your therapy. Otherwise, you may have to change your treatment to a different drug. For example, the second generation TKI like Tasigna or Sprycel. The second 3 months, which is a 6 month BCR-ABL, should drop to less than 1% or not detected. This is also considered an optimal response, and then you continue or you may consider switching. And so on 9 months, for example, the 12-month quantitative PCR for BCR-ABL protein should drop to less than 0.1%. And this is the optimal response or is considered major molecular response, and you continue with therapy and keep continuing every 3 months, and later on you could do every 6 months. But the monitoring with the quantitative PCR should never stop as long as the patient is on tyrosine kinase inhibitor. Since tyrosine kinase inhibitors became available in the late 1990s, we used to give and recommend for patients to take these drugs as long as no relapse and no major toxicities. The question was raised, could we discontinue these drugs? And we found out, yes, we could, as long as the patient fulfilled the following criteria. Criteria for discontinuing TKI. The first criteria, the patient should be an adult, 18 years and older. The patient should have been taking the drug faithfully for at least 3 years. And the patient should have had BCR-ABL test by quantitative PCR. The patient should have achieved major molecular response continuously for at least 2 years. The patient should have an access to a reliable lab doing quantitative PCR test. Once the patient discontinued the drug, should have frequent monitoring with PCR, initially every month and so on. So very frequent monitoring other than the every 3 months. And in case of losing the major molecular response, the drug should be resumed immediately within weeks. And the PCR for BCR-ABL should be checked every 4 weeks until the major molecular response reestablished. Then we can check every 3 months. Take home message. MDS is considered an aging process, but it could be therapy related due to chemotherapy or irradiation or caused by environmental toxins. Evaluate at-risk patients who present with refractory anemia or other cytopenia with a bone marrow test. The only curative treatment for MDS is allogeneic stem cell transplant or bone marrow transplant. AML diagnosis. You need 20% or more blast in the peripheral blood or bone marrow to make a diagnosis of AML. However, certain cytogenetics are diagnostic for AML regardless of the blast percentage. APL is the clinical diagnosis confirmed by cytogenetics and molecular tests for chromosome translocation 15 and 17. APL is an emergency disease, so treat immediately with ATRA while waiting for confirmatory tests. Ph-positive ALL carries poor prognosis. Tyrosine kinase inhibitors such as Sprycel, in addition to chemotherapy, is used for induction, followed by allogeneic stem cell transplant or bone marrow transplant. Another message to take home, CLL. CLL is an indolent disease. Not everyone requires treatment. Observation is very reasonable. Treat symptomatic patients and those with high tumor burden or advanced disease, or those with unfavorable prognostic features such as deletion 17p, deletion 11q, and unmutated IGHV. CML, another chronic leukemia. Tyrosine kinase inhibitors have changed the natural course and history of CML. Tyrosine kinase inhibitor could be discontinued if certain criteria are met. Thank you much.